Today, we are going to talk about epistaxis. Epistaxis is defined as bleeding from nose and is one of the commonest emergencies dealt with by ENT. To manage epistaxis, first, we have to go for assessment and resuscitation. Assess the patient as per acute life support guidelines, looking at airway, breathing, circulation. Patient should be sit up, lean forward, with pressure applied to the anterior part of the nose by pinching continuously. In patients with significant ongoing epistaxis, we should obtain IV access, full blood count, coagulation screening, cross-match. If there are signs of shock, for example tachycardia, hypotension, cold peripheries, prolonged capillary refill time, we should start with fluid resuscitation. In severe epistaxis, blood transfusion can be considered. At the same time, we should also take targeted history to identify the severity of bleeding, site of bleeding, identify any underlying etiological factors. These are the instruments commonly used in cases of acute epistaxis. This is the chlorpheniramine nasal spray, which is used for anesthetic and also vasoconstrictor. This is Tudicum nasal speculum for better visualization of nasal cavity. This is Merocil. This is fast gauze used in anterior nasal packing. Tillis forceps, CMC ointment, headlight for better light source, adrenaline ampoule, gauze, 10 cc syringe, cord clamp, Foley's catheter, ice gargle, biohazard bag. For patients with acute epistaxis, we will start with first aid known as Trotter's method. Sit the patient upright with head forward to prevent aspiration. Pinch the flesh part of the nose firmly. Closing the nostril, apply pressure for 5 to 10 minutes without releasing the pressure. Meanwhile, ask the patient to breathe through mouth. At the same time, use ice pack for ice compression over the forehead. At the same time, use ice water for gargle. This is the sagittal view of nasal cavity. Inferior turbinate, middle turbinate, inferior meatus, frontal sinus, sphenoid sinus, ethmoid sinus, nasopharynx. The most common part for anterior bleeding, which should be on the litus area, also known as Kissable's plexus, which is around this area and is not shown in this model, while the posterior bleeding would be most common at the Woodruff plexus and also nasopharynx. This is anterior nasal packing using gauze with the help of Tillis forceps. Insert the fast gauze to the nasal cavity parallel to the floor of the nose. A common mistake while doing packing is pointing the Tillis forceps outward. It is not effective. The other option of doing anterior nasal packing is using Merocil. This is the Merocil. First, we apply CMC ointment on the Merocil. Subsequently, we insert the Merocil into the nasal cavity parallel to the floor of the nose. After you have inserted the Merocil, flush with subnormal saline for it to expand and provide compression over the nasal wall. In the case of posterior epistaxis, you can proceed with posterior nasal packing followed by anterior nasal packing. Posterior nasal packing, insert the Foley's catheter parallel to the floor of the nose until we visualize the tip of the Foley's catheter from the oropharynx. Inflate the balloon with 10 cc of water or air. Once you visualize the tip of Foley's catheter, inflate the balloon using 10 cc of water or air. Slowly pull the Foley's catheter until you feel a resistance. After the packing is done, put a cord clamp in front of the Foley's catheter to prevent dislodge of Foley's catheter, and we should take extra precaution to prevent pressure necrosis by putting a gauze in between cord clamp and the nose. If the previous method failed to control the bleeding, we should proceed with examination under anesthesia. With general anesthesia, it allows adequate nasal packing, endoscopic examination, and effective cauterization. With surgical intervention, we can proceed with surgical artery ligation, endoscopically, or embolization.